welcome everyone to this month's HHA or Home Health Agency work group hosted by Superior Health Quality Alliance. I'm Christine Lamb, a Quality Improvement Advisor at Superior Health. Superior Health is a regional quality improvement organization operating under the direction of the Centers for Medicare and Medicaid Services. We provide support for healthcare organizations across a tri-state region for free. And I'm joined by colleagues Barb Link, Carrie Finley, and Janelle Shear. See if we can. There we go. This work group meets on the fourth Wednesday of each month, providing an opportunity for HHAs across Michigan, Minnesota, and Wisconsin to connect, offer support, and share ideas and best practices. The format is open discussion, so please feel free to unmute and share how your organization tackles the topics we discuss. You may also post comments in the chat at any time. We do monitor the chat, and we will be posting the link to today's slides in the chat as well. Our agenda today includes some introductions, a discussion on engaging caregivers, and highlights the timeliness of care project we have running, and then a mention of our next meeting topic. So to get started, please share your name, your title, organization, state, and favorite color to wear in chat. And while you're doing that, let's have my colleagues introduce themselves. Take yourself off mute. We'll start with Barb.
Thanks, Christine. Hi, everybody. Good morning. I'm Barb Link. I'm one of the quality improvement advisors here with Superior Health, and I work out of the state of Michigan for Improve Health. I'm a social worker by background and have been with the Home Health Agency work group for a while. And I like to wear kind of a teal blue because I have one of those nondescript kind of eye colors, and it sort of makes them look a little more blue. So I guess I like wearing blue for that fact. And I'll pass it over to Janelle.
Hi, everybody. My name is Janelle Shear. I am also a quality improvement advisor for Superior Health. My home organization is Stratus Health, based in Minnesota. I'm a registered nurse by background, previous home health agency and hospice director in a rural community in Minnesota. And I'm going to say, even though I don't wear it that often, I'm going to say kind of a brighter blue. I've been told it looks good with my hair. So I'll turn it over to you, Carrie.
Hi, everyone. My name is Carrie Finley, and I'm also a quality improvement advisor with Superior Health. I'm based out of Wisconsin, and I'm also a nurse as well. And as far as favorite color to wear, I should share my favorite color is yellow, but yellow does not look good on me. Probably the color I wear most is red. So glad to have you all here, and I'll hand it back over to Christine.
Great, thanks. Yeah, I'll just let everyone know I'm also in Wisconsin, and it was tough for me on this question because I like to wear a lot of different colors, but I've been told with blonde hair and blue eyes, blue is a good color to wear, or colors with undertones of blue. We do have a lot of blue in there. We have someone that likes to wear black. Also, someone else said it's hard to choose one. I am in total agreement with that. One individual likes to wear peach. I love that color. And it's so very soft and calming. Thank you, everyone, for sharing that or sharing in chat. We appreciate it. For today, we have prepared some talking points for the discussion, and these talking points focus mainly on family and friend caregivers. However, the discussion today can also be relevant to other caregiver roles or occupations. So feel free to share any thoughts in that realm as well. So the first talking point here is when scheduling a visit, let caregivers know what the planned goals or services are for the visit. So for example, when you're speaking with a caregiver, say something to the effect of, at this visit, we will review your loved one's care plan, give medications, and check on treatment progress. It's also good to mention the reasons why you'd like them there at that visit and why the visit needs to be done on a certain date or within a certain time frame. And then also consider a range of communication formats. Ask caregivers how they prefer to be contacted by text or by phone or voice phone. Use clear and concise language when talking with them. And when you're in person, remember that nonverbal communication is a powerful tool in caregiving. It does go beyond the words and plays a significant role in sending body language messages and building rapport. Educate them on in-home care versus home health care. I think in many cases, caregivers may not have a good understanding of the difference in the level of care provided, and that home care focuses more on providing help with daily activities, personal care, as well as emotional support. And then home health care tends to focus more on that skilled medical care for folks recovering from an illness, injury, or surgery. And then involve caregivers in the patient's home health care planning. There is a sample link here, but I'm thinking most organizations likely have their own versions that they use regularly on the care planning. And including patients and caregivers in care planning and in shared decision-making outcomes can really help caregivers feel better prepared for when home health care ends. I think right now we'll open it up for discussion and any thoughts or comments. Are any of these things you do or think about in your organization when working with caregivers? And is there any that you would add?
Christine, I'll just make a comment. I really like that first bullet to tell the patient and family the goals of the visit. So I'm here to, do your wound care or do your assessment or whatever, if there's something specifically or a certain type of teaching, so they know right off at the beginning of the visit, the main goal, which is, that's helpful for a lot of things, like when you have team meetings and that kind of thing as well. But I really like that point there.
Yeah, thanks, Janelle.
This is Karen. We recently were discussing how patients have the perception that it's in-home care when it's really home health care, even though they've talked to somebody in the hospital and they've talked to our intake and had a pre-admit call. There still is a lot of confusion over that. So we just try to figure out ways to communicate that better.
Yeah, thanks, Karen. I see Colleen put in chat that they do many of the practices, but they don't really have a standard approach to communication. And that's an opportunity perhaps at her organization. Thanks, Colleen.
I was wondering too, if anybody has any ideas about those family members who feel sort of overwhelmed and scared when you have to do some teaching on something. Maybe their family member was just discharged and, they just want to have them go back to the hospital because they don't think that they're ready to manage it on their own, or, with the support of you or something. Like, how do you deal with those sort of issues?
This is Colleen, but this is interesting because we just had a conversation yesterday with leadership at a hospital, and they were trying to navigate a dynamic where the patient just wanted to be home and the caregiver is supporting them, but they don't want them to go home. They want them to go to a facility because they're not so sure how they can do it, but they don't know how to say that to someone they love and care for. So it was an interesting discussion, and I don't have an answer. I just add to your point of like these are really complex dynamics that we're inserting ourselves into.
Thank you, Colleen. And yeah, we will, in a couple of slides here, you'll see we have some suggestions around supporting caregivers So we'll see more of that coming up. Thank you for mentioning that, Barb. This was a really great spot to bring that up. All right, well, feel free to continue adding stuff in chat. We do have another one here, though, before we move on. Just adding to the point of explaining why the visit needs to be done on a certain day, or if any skill is timed, and explaining the importance as to why, and exploring barriers to set the time. So I think that's a really great point there as well. Thank you. So we will take it to the next slide. So Karen, this may be helpful. It's just an example of a table that can be shared with patients and caregivers during intake or at other visits. And this helps explain the difference between in-home care and home health care. And again, you can modify this if you want to have this table in your in the information you share at the intake or other visits. Feel free to tweak it. I did get this from What is In-Home Care. That link is down there, but certainly feel free to modify it. Just a couple of things that I found interesting here on the medication services. So when you're talking in-home care, it's really, it's probably more like more medication reminders to remind that family member or friend, hey, did you remember to take your medications? And how many times did you take them? Versus that home health care, medication administration. And I'm sure all of you here are well aware of the differences in these. But if we have this table included in the information we're sharing, it could help with that confusion. So I'm just interested to hear if anyone here has something like this that you use, or what your thoughts are on including this in other information. I mean, I know probably the information you provide might be, I don't know if it's lengthy or not, but could a table like this be helpful for your organization to have?
It might be. I would be interested in running it by the group of people that were recently discussing this. We had a intake manager who had a father in the hospital, and she said that the discharge planner really did talk to him about, she had a very brief but a good discussion about what home care is. So she was trying to prove to our leaders that the hospital really does do an adequate job with this, and they use a document that we've provided, but it doesn't have a table like this on it. So this table might be good for the discharge planner and our admitting clinician.
Wonderful. Thank you. That's really great to hear.
It also might be helpful to have how each of those are paid for. Home health care, I'm thinking, is typically like the Medicare or the insurance for the skilled need, and in-home care could be a waiver program or private pay. Maybe some others like long-term care insurance. I'm just kind of curious about what your thoughts are on that. And do any of your agencies offer both services, the in-home care and the home health care?
This is Kay from Henry Ford. Yep, we offer both. You know, Christine, something I would comment on is it says provider qualifications, in-home care caregivers don't need medical training. However, some agencies do require that, you know, there are medical assistants that go through programs. There are home health aides that go through programs, you know, so I don't know how you would clarify that, but that might be a question that if somebody in the community were utilizing this to help decide what agency they wanted to go through for the in-home care, they might want to ask that question.
Yeah, I think that's a great distinction for folks to add in that provider qualifications. I mean, maybe it could be, you know, some caregivers don't need medical training. However, it could clearly be summarized there. And then maybe it's depending on the level of care, you know. Yeah, good point. Again, feel free, if you decide you want to use this table, feel free to modify it. Again, I have the source listed there, but you can definitely make it relevant and change up the things that may not be best represented. All right. And then we do have, Colleen said that, the answer of your question, Janelle, yes, they do provide both. And then Michelle also says that they provide both and agrees that it should say some caregivers do need medical training. So thank you, Michelle. All right. We will go to our next slide. And I think this is going to be one I'm going to hand over to Janelle to lead the discussion on the FCAT tool.
Yeah, I'm just curious, how many of you do some kind of assessment of the family or the caregiver on their involvement or their comfort for managing the care of the patient that you're taking care of? Does anybody already do some kind of assessment? Well, I found this one. You may have heard of Dr. Eric Coleman and his colleagues at the University of Colorado Health Sciences Center. They developed the Care Transitions Intervention Team Care Model. So if you're interested, the website for that is just caretransitions.org. Very well known in kind of the care transitions world. And so they developed this model to address care transition problems that are happening. Typically thinking, you know, hospital to home or where they go, but many of the tools can be adapted. So the care transition intervention focuses on providing support and education to the patient and family caregiver. And so while this model typically focuses on transition of the hospital, this tool that I'm sharing today is useful for all settings and can help you work to engage the family caregivers. So it's called the Family Caregiver Activations and Transition Tool. They called it the FCAT acronym for it. So this tool was developed to foster more productive interactions between healthcare professionals and family caregivers. And when they developed it, they included direct input from family caregivers. So the items are both relevant to actual experiences and are relatively easy to understand and written in words that are easy for a lay person to understand. The FCAT tool was designed to be administered either by the healthcare professional or you could give it to the family caregiver at the point of time of transition or shortly thereafter. So for home health, you might consider completing this or having the family caregiver complete it at admission or at a visit close to the admit visit. So they complete it, and then the care team would review the responses. Those areas that the family caregiver identified as not feeling confident or prepared through completing the tool would be specifically addressed to help them at the visit. So if you look at some of these questions, you know, it's like I'm able to make sure my loved one goes to every scheduled appointment. So then they rate it, you know, 1 to 6, how confident they feel about that. The one I really thought would be especially helpful is that number 3. I know what things to watch for that would mean my loved one's condition is getting worse and how to respond. You know, we have a lot of tools out there and information, but you want, you know, think, is it in I want to say language, but is it written in a way that is understandable to people that don't have medical background? And then they talk about medications. I have an accurate list. They are involved with the actual appointment. They have a pharmacy in their community they can contact. I keep a written record. Now that would be interesting. How many do that? I keep a written record of my loved one's health conditions, allergy meds, along with the professionals that are treating them. And then I understand which of the instructions in my loved one's care plan are most important and need to be completed. And then the last one is if my loved one needs to get help from a healthcare professional, I'm confident I can insist until I get what is needed, so that takes a lot for some people to have to insist. I'm going to just put the link to this tool in chat there if you want to take a look at it. But just thought it'd be interesting to see if you use anything like this or what you think of using a tool, or if you'd pull out certain questions, or maybe it's some of these already in your EMR or your patient record.
I think that during the nurse's assessment or the therapist, if it's a therapy only case, they try to elicit answers to these questions, but we don't have a tool printed out like this that they follow these questions.
Kay, is there anything in your EMR that addresses this, or are you saying the clinicians themselves just engage people in?
Well, we have to determine who the caregiver is. We have to determine who the caregiver is. And then they determine if there are, we ask a question about transportation issues and who takes the patient to the doctor. They look at all of their medications and that's the number one issue at a start of care is the med reconciliation. 99.9% of the time something is off, right?
Right.
And then, because we are an integrated system, they're able to send a communication to the doctor at the end of the visit with the concerns, so that helps. Now, does the doctor always respond? No, but, they do alert the doctor to the concerns, especially regarding the medications and then any equipment they need or, whatever concerns they have.
Thank you.
I'm sorry.
Go ahead, Colleen.
We attempted to do or insert in our narrative template a brief assessment of the caregiver on start of care. But the problem was it was a narrative and it was too hard it was a manual audit process, so it didn't last long. Since then, we have changed EMRs just in the last year, and there, even for home care, hospice has a bit of a caregiver assessment tool by the social worker, but home care really still is it's not there. So interesting.
Yeah, we use Epic and it's a hard stop and I don't know if that was built into our assessment, but it's a hard stop, whether the patient has a caregiver or not. And the availability of the caregiver, is it 24 hours? Is it only during the day?
That's it. That's what we all need. That's great. It makes a difference when you're thinking about how to set up your care plan.
Great. Anybody else want to share or?
Well, and some of it is all about time. And if you do have a social worker on staff, hopefully they'd be able to help out with this too. But I think, yeah, like when Dr. Coleman was developing this, some of it was to get at some of those questions. Like Colleen, you were referencing that one family member who was just very concerned about bringing the patient home, like trying to maybe get at a number or make it a little bit safer for the person to start thinking about these questions, and then have someone there from either the discharge plan or home care agency be able to talk through it with them. But again, those can be long conversations, but I think could be very beneficial for people. Especially, I agree that one about, do you feel like you can really advocate for your family member? If they feel, if they answered honestly that they didn't feel like they could be that assertive, how could, we help them with that? How could we anticipate some of those things? I always really liked this tool.
We will now move on to support for caregivers. So involvement in the care planning and shared decision-making, along with having supports in place for when home health care ends, can boost their confidence in their abilities. So sharing supports early on will allow caregivers time to research and ask questions at the next visit. Let them know that you really do welcome their questions, that you're here not only to help support their loved ones, but help support them too, so that they have a higher confidence level in themselves. These are some support sites to consider. AARP, that website has some downloadable caregiver guides. They can locate services and support in their state, and I think even down to the community level. They can find support for different caregiving situations and medical conditions. There is an online community where they can chat with others within that online community. And then there are several videos in this family caregiving how-to video series. So that's the AARP. And then the Caregiving Resource Center just really has a lot of resources to help them navigate caregiving. We did include this disclaimer here that they have on that site that it really is for informational purposes only. But a lot of the information they have there can be really helpful. So I am sorry, I was reading, someone needed to hop off for another meeting, so, and is looking forward to the recording. So I just wonder, are there other resources or sites or referrals that folks tend to use to offer supports to caregivers? Are you still looking for more support resources? Is there something here that, or is there a resource that you guys, that anyone is really like, we like this particular resource to support caregivers and help them get maybe some of the training that they need? Elder Care Locator. Yeah. Thanks for including that, Barb. No other suggestions? Well, I mean, just to mention that we know that the internet has a lot of resources out there, even for caregivers to maybe look for themselves, but also for maybe representatives in your organization. Sign someone like a half hour one day and say, hey, go out and do a search and see, are there some resources out there that we can add to what we're providing caregivers? And let me know what you find. Thanks, Clover, for that specific to Wisconsin resource. All right, we're going to take it to the next slide here. We have some discussion questions here, and I think we might have kind of touched on some of these, but just curious, what has worked well, really well for folks to engage caregivers? We've already talked about a couple of pain points that we did discuss today, but are there others that anyone wants to bring up for the group here? Maybe there's some tips or best practices we can talk about. Nothing jumping to mind. Is time often a barrier where when you're at those visits, maybe caregivers, I mean, to help engage them and help them and support them, would time be a barrier?
I think time is a barrier. We do document a return demonstration to prove that the caregiver can provide the care, but we've also experienced many caregivers saying, yes, I can do that in the hospital. No, I can't do that once they get home. And sometimes other arrangements have to be made because, you know, it's an elderly couple and he really doesn't have the dexterity to do the IV himself, and she can't do it for herself. So there are definitely challenges. And then too, sometimes with home health, people want us to keep coming and doing the wound care rather than the caregiver doing the wound care. So we've worked really hard at making sure they understand that our policy requires a caregiver and we can't come back for daily wound care. We have to teach it.
Yeah. I mean, do you ask them, like, maybe the question, you probably do, Karen, because I know how fabulous you are, but what is the main part of that caregiving process that they're struggling with? Like, what is it that you're scared of the most? Or what is it that you feel like you can't do?
Yeah, I'm sure it depends on the clinician. It's different from clinician to clinician. Some of them just have, a much better way with communication and relating to, and even sensing what the issue is, seeing without being told what the issue is. And, they're able to address it. And some people are just a lot more straightforward in their approach, which may not work for everybody.
Right. Yeah, I think that's, we've got Clover in the chat. She was talking about that time and confidence. And she says, they do ask questions. She or he. I never thought I would have to do this. Like when a caregiver says that, like I really never thought.
I know another challenge that we have with caregivers, and it might be off topic, but when we're going into group home settings and we're working with other caregivers of the group home, and that turnover in care and trying to establish a safe handoff, it can be challenging, and yet it's a different type of caregiver, right? It's not the caregiver that are attached by friend or family. It's someone else's employee, but they're the person there 45, 60 hours a week. So it's been challenging, and I do get staff that seem to be frustrated at times with that as well.
So we will move to the next slide, which is a project highlight, and I will pass it off to Barb.
Thanks, Christine. So I think it was almost 2 years ago. So one of the things that this home health agency work group did was decided that we wanted to work on preventing ED or emergency department use, overuse, and then also look at how to reduce hospital readmissions. And so the group that was meeting at the time, some people I know were here at the time who were attendees today. We did sort of a root cause analysis to see what were some best practices that home care was doing, or the challenges that home care had in the area of their patients going to the emergency department without calling them first, or not being able to engage the patient in a timely manner so they wouldn't go back to the emergency department or end up being rehospitalized again. And so we developed a tool, our timeliness of care scripting tool, that we use to help try and reduce or engage patients in a timely manner once they were discharged from the hospital, so they'd accept home care services and not use the ED because they were concerned or they weren't engaged quickly enough in the home care services. So we developed a whole training video. It even has a role play embedded in it. We've got a very nice tracking tool, and we have the script for people to use. Some of the home care agencies stated they didn't have like a standardized script for their intake person or for someone who tended to engage the patient right away in care. And we use some means of using like different interviewing techniques and all sorts of things that we came up with. And so once we implemented it, we did want the attendees, and we sent it out to all home care agencies that were involved in Superior Health to start using it and tracking to see if they had any positive outcomes from starting to use the scripting tool, and sort of do some pre-scripting tool, post-scripting tool. But we know you're all busy and have a lot to do. So we didn't get a lot of uptick in engagement in that. We had some home care agencies tell us that yes, they were using the scripting tool, but really didn't have time to use our tracking tool, and that sort of thing. So at that point, we luckily enough were able to engage Allie Doran. She's a PhD student, and she's been doing some outreach and has been trying to contact some of you and some of our other home care agencies that have been involved in the past. And she's with us today. We're very happy to have her here to talk a little bit about some of the things that she was hearing as she was doing her outreach, as well as what we're moving into to try and get some data around this intervention as well. So I'll turn it over to you, Allie.
Yeah, thank you, Barb. Hi, everyone. So like Barb mentioned, I've been working with home healthcare agencies on reviewing the effectiveness of this scripting tool when making those initial phone calls for home services. So really at its core, what I've been trying to do is provide support in the process of what it looks like when you initially get a referral to when you make that initial phone call. So I'm speaking with various home health agencies, I'm finding that everyone has very different processes and to accept referrals and then to actually have that phone call and what they're saying in that initial phone call contact. Each agency also has different ways to collect the data. So mostly it's through their EMR system. And some agencies are reporting that their current process is effective, but they may not be collecting data or they're not reviewing the data to really identify and kind of keep track of those acceptance rates over time. So recently we developed a questionnaire which is designed to gather some information that we're looking for that will help sort of pinpoint the areas in that process of where we might want to zoom in and take a closer look at. And really the scripting tool is designed to have 6 different elements for making that phone call and providing the information to allow that individual hopefully accept home services in a timely manner. So if anyone is interested in receiving support on how to increase acceptance rates or just improve their process in setting up these initial home visits, I'd be more than happy to provide that support and collaborate with you. What I've been doing is sort of comparing, what your current process is to what we have that Superior Health has developed, and then picking at elements that may be beneficial to you, and then help collect some of those data to really evaluate and measure if it's effective or not. So if it's helpful, I can put the email in the chat. And please, I check this email regularly, so please feel free to reach out to me and I'd be happy to set up a phone call or a Zoom call, or just through email if that's the better way to communicate and support you in any way. So thank you. Thanks for having me today.
Yeah, I'm just curious if we have anyone in the group here today that has been working with Allie, and if yes, if you had any comments or feedback, it's okay if we don't have anyone here today. I'm not sure who's on her list that she's connected with, but not to put anybody on the spot for sure. Just was curious if someone was here and wanted to share. Okay,
This is Karen again. We have not worked with Allie. I didn't know about Allie, but we've been doing an A3 on scheduling. And it's a large group, interdisciplinary group, trying to improve the scheduling process. And our pre-admit call has been one of the topics in that, like who's doing it, not necessarily the content of the pre-admit call, but who's doing it, when is it being done, what are the barriers to the reaching the patient. So it just makes me wonder if she would have any insight to all of that.
Yeah, I would be happy to discuss more with you and see if we can figure out solutions. I'd be happy to do that.
Okay.
Great. Everybody feel free to grab that hat tool at superiorhealthqa.org if you would like to reach out to Allie. Thank you, Allie, for being here with us today to give an update. Barb, did you have something to add or just come off
Well,
mute?
you know what? I just realized it's a dash off topic, but maybe not. So I don't know if we ever told this group that we had a poster session accepted at CMS on our timeliness of care intervention, along with our toolkit on call us first toolkit. So that was really reinforcing that please call home care first before you decide to go to the emergency room or decide to go back maybe to the hospital. And that has a lot of wonderful resources in it as well. But I remember, Christine, and I know you and Carrie went to CMS to present the poster. But one of the things, it was other quality improvement organizations who attended that conference, and they were just so impressed that we had a group like this, and that the group members were willing to share their their challenges and their successes, and just made me think of that even today, how wonderful it is we all just learn from each other and that sort of thing. And that's where this tool came from, was from everybody attending this group and trying to figure out a way to address that issue. But that was just one of the things I remember you talking about when you were there, that they just thought that was so impressive that people were willing to meet like this and trying to develop interventions.
Yeah, thanks, Barb, for bringing that up. I think there was so much activity around that poster, and at that conference, this was in April, it was the only poster presented and accepted by CMS around working with home health agencies. So I think the participants who were kind of going up to that poster, Carrie and I eventually were like, oh my gosh, do we really want to keep standing by this poster? Because we had a lot of questions about, how did you engage home health agencies? Like, how did you get this information? How did you do it? So Barb, appreciate you bringing that up. And really what Carrie and I had expressed is, we have a work group, we do what we can to engage folks and provide some things that they might need. So anyway, thank you, Barb, for bringing that up. That's one of the really great reasons we really enjoy this work group. All right, so moving on, our next meeting is next month on embedding value-based care in home health. And just a reminder, we do currently have an HHA work group in Connect, and that's where we post slides. I'm going to put the link in chat now for today's slides for those that want to grab that. And you can always join HHA work group and Connect. And then if you have any questions or are in need of any other supports, you can contact any one of us listed here on the slide. We do, of course, have representatives in Michigan, Minnesota, and Wisconsin. However, you don't really need to say, who was that person in Michigan or who was that person in Wisconsin? You can reach out to any one of us. We're here to help. And we meet on a regular basis internally. So we'll be communicating any needs that folks have if we hear about those. And then this is the link to Superior Health's main Connect page. We've had a great discussion today, so I just want to open it up if there are any final thoughts or questions before we sign on. Okay, hearing none, thanks again for joining us, and we'll see you next time.
Thank you.
Thank you.
Thank you.
Thanks.